ACE inhibitors reduce SVR. What's that mean? Total peripheral resistance, systemic vascular resistance. How? You don't have as much angiotensin II. Here you go. Reduces remodeling. ACE inhibitors, first line of therapy with CHF because of the ability to reduce remodeling. What's that mean? You do not introduce the repair process and cause further harm. Do not start if your patient has acute renal failure. Is that understood? A lot of times, remember, there are instances in which the kidneys require angiotensin II so that it can restore GFR or maintain GFR. So you please make sure that you pay attention to a renal status before you do give your ACE inhibitor. We talked about this earlier when we did atherosclerosis with renal arterial stenosis as well. Keep that in mind. In addition, the side effect that you're looking for is a dry cough. In addition, you have the inability to properly metabolize what component with ACE inhibitor that results perhaps in cough. It's called bradykinin. Bradykinin. What kind of effect does bradykinin have on your blood vessels? Increased vascular permeability. So what do I sound like? What's that mean? Angioedema. What's happening? The blood vessels around my mucosa, oral mucosa, undergoes vasodilation, increased capillary permeability. That's not how I talk. You know that. That's just my impersonation of angioedema. Will you forget this? Never. So ACE inhibitors, inability to properly handle bradykinin. Know that for any exam, you'll be in good shape. We talked about cough, angioedema, renal failure. What about this hyperkalemia bit? Important. Oh, yeah. Remember, please. In addition, ACE inhibitor with angiotensin II and bradykinin, aldosterone does normally. What kind of effect does aldosterone normally have on potassium? It gets rid of it. If you have ACE inhibitor, you don't produce aldosterone from your glomerulosa. So therefore, you're going to retain your potassium. Hyperkalemia, not good for whom? If you have hyperkalemia, EKG, T-tenting. Next, more importantly, what happens? The threshold, the resting membrane potential and threshold. So the difference between those two, what happens now? Is that resting membrane potential going to become more positive or is it going to become more negative? You answer that question way back in basics. Everyone loves this question, as should you. It's the fact that the resting membrane potential will get closer to threshold. It'll depolarize. It gets closer. That's not a good thing. Very scary. Very scary. Especially for the heart. Beta blockers. Metoprolol, carvedilol. You knock out the beta-1 receptors. Should not be used in patient CHF. It may blunt the tachy. Be careful. And so therefore, remember, if you knock out the tachy, that might be a compensatory mechanism that needs to be taking place. So be careful. Side effects: brady, heart block, hypotension, bronchospasms. Why? Especially now, be careful. Even when they say selective beta-1 blocker like metoprolol, is there such a thing as a guarantee? No, right? So just because you say selective, general scheme of things and definition, sure. However, is there a possibility that it might also have beta-2 blocking effects? Sure. What are you breathing in to relieve asthma? Inhaler? Beta-2 agonist. So there's every possibility that by giving a beta blocker to a patient that has asthma, you exacerbate the condition. Please be careful, please be careful, please be careful. And that tachycardia is huge as well, because there are times with a beta blocker that it might mask the events that might be taking place to clue you in that your patient might be going into hypoglycemia with diabetes. Okay? Keep that in mind. That's a huge pharmacologic point. So once again, if you want to review some of your pharm, take a look at the conditions what conditions would then exercise caution or great caution when using beta blocker. For sure, bronchospasms and diabetes mellitus are two big ones. Okay? Nitrates. We talked about this plenty. It's the fact that here you have your longer acting, cause of vasodilation, both the venous and the arterial, decrease TPR, and it also decreases your preload. In addition, used in combination with hydralazine in African Americans to decrease mortality. Side effects: hypotension, headache, and tolerance. ARBs, angiotensin receptor blockers, pretty straightforward, very analogous. If your patient is having dry cough and some of the intolerance of ACE inhibitor, then you will start thinking about using your Lortans, right? Losartan and such. Side effect, hypotension, angioedema, you see, dry cough is not here. Spironolactone, what are we doing here? The 5 different classes, the 5th and final. Here's your class 3 and 4, heart failure. What does that mean? Minimal exertion. Oh no, I'm having symptoms. 4, even symptoms at rest. Hey doc, I can't even sleep on my bed. I can't even sleep in a supine position. Well, they're not going to tell you that. But I have to go sleep where? On my recliner chair. Sad. 3 and 4, indicated, spironolactone. If you knock out your aldosterone, you have hyperkalemia, hence it's called potassium-sparing drug. And not only that, but spironolactone has what kind of effect? And this is the other hormone that it can also antagonize. Please tell me what that hormone is. An androgen antagonist, isn't it? Where does that come in handy? Something like polycystic ovarian syndrome. Who's that patient, polycystic ovarian syndrome? She's a female, genotypically XX. She walks in, but she has hirsutism, male-like hair features. So there's a lot of androgens in that patient, polycystic ovarian syndrome, and that's clinically true because you're actually looking for LH being greater than FSH. You with me here? If you don't, that's okay. That's quite all right because you will come into spironolactone. Later on, we'll talk about polycystic ovarian syndrome and how you want to manage that. And we will talk about spironolactone because it's an androgen antagonist. But in the process, may give you gynecomastia. There is something called ICD. You want to make sure that you at least know what it stands for. Implantable cardioverter defibrillator. Nowadays, you know that it's pretty much found everywhere and anywhere, thank goodness. Advanced heart failure because you're worried about that arrhythmia. And, with these, hopefully you'll be able to prevent from arrhythmia kicking in. And we talked about what arrhythmia means. It just means that once you disrupt the architecture of the heart, then you are prone to whatever type of arrhythmia it may be. Now, a couple of things here. Post-MI, 40 days. Implantable. Or non-implantable with ejection fraction less than 35. And here, once again, class 2 and 3, which means that you have moderate exertion with symptoms and minimal exertion. Please make sure you go take a look at your New York Heart Association classes so that you're familiar with the symptoms of your patient. Side effects, expenses, obviously, quite, complications. Not all will benefit, and inappropriate shocks that you might be feeling with a defibrillator, which a patient might then be complaining of.